All right, guys, so welcome to the fourth step of the nursing process, which is implementing. It's the purpose of implementing some of those interventions that you wrote out and really working on the plan of care, the fabulous plan of care that you've written for Mrs. Carla Tompkins. So let's talk about what you're going to do in this step of the nursing process. You're going to help the patient achieve their goal or outcome. You're going to promote health, prevent disease and illness, restore health, hopefully by allowing the patient to meet those outcomes that you've written for them, and facilitate coping with altered functioning. Okay, so let's look at implementing a little deeper. There are some interventions that you wrote out for Mrs. Tompkins. Interventions can either be direct or indirect. And if you just think about what the word means, it's telling you exactly, what the definition is for nursing interventions. Direct nursing interventions are treatments performed through interactions with the patients. So there's direct interaction, inter, you know, the interventions are being done through those interactions with the patient, such as administering her pain medication. That's a direct intervention. Indirect care intervention is a treatment that's performed away from the patient but on their behalf. So, for instance, maybe you meet with her physical therapy team and you talk about how much progression she's made in her physical therapy, or you talk to maybe a chaplain or set her up with case management or social services to have support for a support group for those struggling with amputations and the psychological effects of that. So those would be considered indirect care because you're doing it for her, but you're not really with her. You're not interacting with her through those interventions. And when you create interventions, you might be using things like standing orders, protocols, or nursing actions or orders. So just depending on what your unit has, they might have things called standing orders, which are orders that are just there for patients, like maybe post-surgical. There's standing orders for vital signs. So we take vital signs every 15 minutes, and then we maybe take them every hour, and then we take them every 4 hour post-op. That would be considered a standing order. A protocol is dealing with somebody who comes in with a specific diagnosis, such as maybe a heart attack in the ER. They definitely have a protocol for treatment for every patient that comes in with a heart attack or stroke or whatever medical diagnosis they might have. And then the nursing actions or orders are things, treatments or interventions that we do independently. Remember, we have nurse interventions, we have physician directed interventions, and then we have collaborative. So those are all the things you might use to complete your interventions. Let's do a knowledge check here. Which one of the following nursing interventions is an indirect care intervention? So we're looking for indirect care. Is it that a nurse explains available birth control measures to a young couple? Is it that a nurse meets with the collaborative care team to plan nursing measures for a patient? Is it that a nurse prays with a patient prior to surgery? Or is it that a nurse administers pain medication to a patient with end-stage renal cancer? Well, if you said B, a nurse meets with the collaborative care team to plan nursing measures for the patient, you're absolutely correct. So just remember, indirect care interventions are on behalf of the patient, but not directly through the interactions with them. Okay, so let's talk about how we reassess and review the plan of care. So we're going to go back after doing any type of intervention with a patient, and we're going to reassess. So an example would be with Mrs. Tompkins. If we give her her pain medication, then we're going to go back 30 minutes to an hour later, and we're going to reassess to see if there's a change in status. So did the pain medication work? Did the interventions work that we did for her? If not, we're going to start to review and think about how we might make changes. Make sure that when you're doing any type of nursing action, that they're safe for this particular patient and individualized to the patient. So for a pain medication, when we go in, we want to make sure we're absolutely assessing the vital signs of the patient before administering that pain medication, because we don't want to give a patient a pain medication, even if they're in pain, if it's going to cause a safety concern for that patient. Identify any barriers, both healthcare and patient. So barriers that you might see: when there's healthcare barriers, that means that there's something going on with the resources in the healthcare facility. So, for instance, maybe there's not a resource that the nurse needs to effectively help the patient meet their goals. So, if you write a goal that the patient will maybe use a walker to walk and there's no resource for a walker, you're not able to get a walker because the whole facility's out of walkers, then you have a healthcare barrier. If there's a patient barrier, it means that there's something going on with the patient that's causing a barrier. Maybe they're not non-compliant, maybe they're not interested, maybe they just aren't really doing what we're needing them to be doing. That would be a patient barrier. Also, lack of support, resources such as financial or family support can also be a barrier for patients. Be sure that when you pick interventions that research supports those, so that would be called evidence-based practice. So when we do things, we want to make sure that they are backed by some sort of research. So every intervention that we do for our patients typically has been researched, and so they know that by a patient laying in bed, by turning them every 2 hours or repositioning or propping or using pillows or whatever you want to say, that we're reducing their risk of pressure ulcer formation. So that has been researched and we're using that intervention. Always monitor the patient's responses to your interventions so that you can modify. So make sure that you're going back and reevaluating what's going on with them. Have they had a decrease in pain? Are they more comfortable? Is she not grimacing as much? So we're always monitoring her responses. And then be sure that each intervention is consistent with professional standards of care, protocols, policies, and procedures of the institution. So we can't come in and do anything that's not obviously approved or consistent with professional standards. So we can't try, a special therapy that we've heard of for pain or something that we've done, maybe, that has worked for us for pain. We can't really do that with the patient unless it's something that is consistent with standards, protocols, and procedures of the agency. So let's do a knowledge check here. Which example illustrates a nurse variable influencing healthcare patient outcomes? So remember, this is looking at the healthcare variable or the nursing variable. So would it be A, a patient in a nursing home refuses to take his medication? B, a low income family is unable to afford formula for their newborn infant? C, an alcoholic patient is unwilling to participate in AA meetings? Or D, a victim does not receive counseling in the emergency department because a counselor is not available? So if you said D, a rape victim does not receive counseling in the emergency department because a counselor is not available, you're absolutely correct. Answer D indicates that there's some sort of healthcare resource that's not available for the patient. So they're not going to be able to meet their outcomes easily. Why do patients non-comply? Well, this could be debated for a long time, but there are some known factors that cause a patient to have non-compliance with a treatment regimen that we've written for them or a plan of care. Lack of family support is a huge indicator. That's why understanding if that's a strength for them or a limitation, we need to know that off the bat. That way we can help with those things and get them the support that they need. Lack of understanding about the benefits. If they're not seeing the benefits of the treatment or what we're doing, they're not going to have buy-in. Once again, low value is attached to the outcomes, so if they don't see the value, they're not going to necessarily want to reach those outcomes while they're in the facility. Adverse physical or emotional effects of treatment. So we can think about maybe if a patient has to undergo some sort of chemotherapy or some medication regimen or treatment regimen that causes them to have physical or emotional effects, they might feel that the illness itself gives them less effects than the actual treatment. So they might not want to do it, and there might needs to be some education there to help the patient see the value of the treatment. Inability to afford treatment and limited access, those are always things that we need to think about with our patients, making sure that they can afford the treatments that we're recommending or wanting them to do, making sure that they have easy access to wherever the treatment is or whatever they need to be doing, that they have home health set up or whatever needs to be done. So we want to make sure that the patient can comply if they'd like to and not have all of these barriers around them. Little knowledge check. When a patient fails to cooperate with the plan of care despite the nurse's best efforts, it is time to reassign the patient to another caregiver. Is that true or false? Well, hopefully you said false. We don't want to just get rid of our patients if they're not doing what we want them to do, unless there's a safety concern for the patient or the nursing staff. But we want to really work with the patient, maybe help them, encourage them, redirect them, maybe work with them a little bit. And remember, not every patient wants to change the things that you think they should be changing. And if a patient, if you know that they have lung cancer and we want them to stop smoking, but they continue to want to smoke, sometimes there's just, nothing you can do about that, and you just need to be okay with that. Okay? All right. So let's look back really quick. I want to go back to our little template here. So the implementation step in a nutshell is just implementing all of these things that we've written out for Mrs. Tompkins. So you went ahead and you wrote out that she has acute pain, and that we want her goal to be that she will state a decrease in pain from 4 out of 10 after pain medication administration. Then we're going to go ahead and we're going to intervene. So in the implementation step, we're going to intervene by doing these interventions. So we're going to assess her pain, we're going to teach her about the pain medication, maybe the side effects, why she should be taking it, when she should be taking it, etc. And then we're going to administer her pain medications. After we do those things, we're going to go back 30 minutes to an hour later and we're going to reassess her. Mrs. Tompkins, can you rate your pain now on a scale from 0 to 10? We're going to see what she says. Okay, so next we're going to move on to evaluation, and we'll evaluate if what we did for Mrs. Tompkins worked.